So my talk is mainly aimed towards the trainees. And I know that there are very experienced neurologists and all physicians as well as other specialists here. And I apologize for some of these slides may be not directed towards a specialist audience as such. But we got a bit to cover through, so let's proceed. Yeah. So what I'm hoping to cover today is to talk about the stroke. As you know, is divided into hemorrhagic strokes and ischemic strokes. I have specifically not touching on the hemorrhagic strokes. What I thought was I will probably highlight in Australia what the facilities and what the protocols we proceed for ischemic strokes as such. And even on the ischemic strokes, as you know, that it doesn't end on the day one. It goes on from hyperacute to subacute to then rehabilitation. What I am planning to concentrate today is the first 24 hours of care of ischemic strokes. And what we will talk about what the treatment options are, and together with some case studies. And at the end, we will talk about the challenges we face here in Sri Lanka, as well as in the first world country like Australia or the UK. And you'll probably find out the challenges are not too much different to each other. You're very welcome to ask me any questions, and probably stop me anytime, or we will have some time at the end until we got about 45 minutes. Yeah. Right. So this is an old slide. We all know thrombolysis for ischemic strokes. We use alteplase, and there's emerging evidence for tenecteplase for thrombolysis as well. And based on the guidelines, Sri Lankan guidelines, I figured out that alteplase is the main drug that we use here. But in Australia, we use alteplase as well as tenecteplase for stroke thrombolysis. So when a patient comes and asks, we have to when we get the consent for treatment, the first question that a patient asks is, what is the benefit and what's the risk associated with it? So we always use this card, which is a very nicely, very summarized aspect of the risk and the benefit. So the way we could probably explain to someone is that if you were treated, if I were to treat 100 people, there will be 32 good outcomes. When you say good outcomes, these patients will be walking out of the hospital with minimal disability. And 3.5 patients will have a bad outcome. These are major hemorrhagic strokes. And if you have a bad outcome, nearly 50% of these patients will not survive. Now, this was based on the thrombolysis data alone. But if you add endovascular clot retrieval or ECR, in other words, we pull the clot out through neurointerventional interventionalist help, we will add another 15 odd patients to that benefit group in addition to thrombolysis. And in fact, we will not increase the risk of bleeding complications, because some of the patients we will otherwise treat, taking the risk, we will take these patients out and send for clot retrieval alone. So it shows that thrombolysis was a great outcome for stroke, but now having the benefit of clot retrieval, that has enhanced the benefits of hyperacute care. Now, if you look at these trials, now I remember these trials went hand in hand. The thrombolysis, there was a group, pro-thrombolysis group, who had all the trials on thrombolysis. On the other hand, there was another group thought, look, thrombolysis is good, but to proceed further, we need to take another step back. What about the patients who cannot be thrombolyzed? Would it be better if we actually put a wire into the intracranial arteries and pull this clot out? And what they found was until 2015, there was no added benefit found on endovascular clot retrieval. So all trials were negative trials from the interventionalist point of view. But then came 2015, there were about 6 or 7 landmark trials that came up. And all these trials were proven that actually a pot retrieval, if you do it right, would have a significant benefit. And you can see that the intervention arm is significantly, you could see that it shows a significant benefit over the thrombolysis alone, because the control being the thrombolysis. Now, what is the reason for that? The reason being, when we first started pot retrieval with techniques, our techniques were not good because everyone was learning how to do these procedures. And the other one was the imaging criteria. We were based on all our patient selection on plain CTs or MRI scans alone. But perfusion scans were not there. CT angiograms were not as precise as they are now. And finally, the patient selection was also not good. So all these have come miles and miles forward from where we were before. And as a result of it, the benefit from pot retrieval now far outweighs than how it was about 15, 20 years ago. Now, to understand my next slide, you might need to know what modified ranking scale is. Modified ranking scale is something that we specifically use for strokes and for patients who have got to assess the functional status of a person. And basically, modified ranking 0 means most of us here, we do not need any aids and we are fully independent with it. And modified ranking scale of 1 means no major aids, but need a bit of, we are not perfect, but not, we still manage our day-to-day activities with the mild disability. So from a stroke point of view, where you need to be is 0 or 1 with modified ranking scale. 2 is a bit borderline. They still can use aids, but they are still independent with it. So 0, 1 is perfect. 0, 1, and 2 are good outcomes from strokes. From 3, 4, 5, 6, you don't want to be in that category once you have had a stroke. So what they found was here, if you look at the thrombolysis data here, intravenous thrombolysis TPA therapy, and if you look at the intravenous TPA alone, this is the thrombolysis alone. You can see 28% of the group fall into this category. But if you put TPA with endovascular clot retrieval, you basically double that number of percentage that you will have a very good outcome as such. So any center that deals with hyperacute stroke, now either from the facilities they have or facilities from a referral center will probably be included in the latest protocols that they would have. Now, I'll quickly go through the time window of hyperacute stroke, because if you look at the hyperacute strokes, there are so many trials that have changed the time scale of how we treat, how far we can go to treat our stroke patients as such. Now, if you look at this is the first trial, intro-stroke thrombolysis, major trial in 1995. That's when the first evidence came, stroke thrombolysis actually does make a good difference to a patient. And this was up to, based on a CT scan, and thrombolysis up to 3 hours. And then came ECAS-3 trial. There was a big gap between that to the next one. And that's the time when we extended the time period up to 4.5 hours. Up to now, any patient who can be treated with a plain CT alone, we have a time scale up to 4.5 hours. And even with major advances, we do not have this time scale extended any further for thrombolysis alone unless you have advanced imaging than just a plain CT. So ECR trials, as I said, 2015 came up. These trials extended the time window up to 6 hours, but this is for clot retrieval. For 4.5 hours up to thrombolysis, clot retrieval up to 6 hours. But there was a diffuse 3 and a DAWN trial came in 2018, which extended the clot retrieval, time window up to 24 hours. So what do we have so far from the trials? We know that plain CT alone, we can thrombolize someone up to 4.5 hours. If you are looking for clot retrieval, not necessarily thrombolysis, just the clot retrieval, this can be extended up to 24 hours. Now, Extend trial in 2019, that basically showed they extended the time window from 4.5 hours to 9 hours. But this 4.5 to 9 hours, you need to have a CT perfusion or advanced imaging. If a hospital does not have a perfusion scan, our time window would be still up to 4.5 hours. Is that clear? Right. And then Wake-up trial, these are MRI-based thrombolysis and clot retrieval. And I'm not touching on the MRI today, but if you have MRI scan, you can actually go beyond 4.5 hours for clot retrieval as well. If the facilities are available, this is a fantastic way of acutely treating patients. But in most of the centers overseas as well, this is not a luxury that hospitals would have. Specifically from my hospital where I working at the moment, I can't get an MRI scan immediately within an hour of someone coming in. I would probably push them if my CT scan has broken at that time, but very selected patients will get an MRI scan within that short period of time. Right. So what do we use in hyperacute imaging? So plain CT, I'm not going to go in too much details. What do you look at this plain CT? First thing is to make sure there's no bleed before you do thrombolysis or clot retrieval. Rule out significant ischemic injury. And that's where the aspect score will come into picture. I'll explain this a bit more. Then we do a CT angiogram and identify an occlusive clot. And then a perfusion scan, identify a salvageable ischemic penumbra. So these are the three triple scans. When you talk about stroke and triple scans, these are the three scans that a comprehensive stroke service will use before analyzing a patient. But you will hear that not all three scans are required for every patient, but as the time window passes beyond 4.5 hours, you will require all these three scans. So this is an algorithm for any of the registrars who are working in the emergency department and to figure out which patient I need to immediately attend, or which can probably take a bit of time because they will be not eligible for lysis as such. Now I'll explain this a bit more. So if you can see acute ischemic stroke presenting within 4.5 hours, the first thing you need to find out is whether this patient has a large vessel occlusion. Because if the patient has a large vessel occlusion, this patient, if the CT scan is favorable, everything is favorable, this patient can be thrombolized because he's within 4.5 hours. Plus, the patient will be eligible for clot retrieval. But if there's no clot available, then this patient will be thrombolized alone. So what do you require for that? This arm, you may not need a perfusion scan because up to 4.5 hours, you can manage with a plain CT alone. On the other hand, if you have a clot here, and if you are going for clot retrieval or large vessel clot retrieval, all patients require a perfusion scan. I'll explain to you what a perfusion scan, what we look in that. So advanced imaging is required for clot retrieval. Charita, can I ask, we have clot retrieval facility, I'm sure here in Kandy we have that, do we? Thrombolysis. So where do you send do you send any patients? Limited numbers. Practiced here, right. We'll talk a bit about that. Then, what if beyond 4.5 hours? So beyond 4.5 hours, we look at clot retrieval. If there's a clot available, you straight away go for clot retrieval. These patients, because 4.5 hours has gone, we do not thrombolyze these patients. On the other hand, if there's no clot available, we go on to that extend trial to see whether this is 4.5 hours to 9 hours. So 4.5 hours to 9 hours thrombolysis is only meant for patients who are not eligible for clot retrieval. But if you do not have a facility for clot retrieval, and if you have a perfusion scan, these patients can still be, let's say in Candy here, if you have a perfusion scan, these patients are eligible if there's a large penumbra, these will be eligible for thrombolysis. Guidelines, according to the guidelines, if you do not have a perfusion scan, our window stops at 4.5 hours. I hope it's clear. Right. So how do you, these are mainly, next few slides will be mainly for trainees. So how do we train our eyes to look at a ischemic stroke? Now, this is an easy one. Now, most of us will identify this as ischemic stroke here, but reality is most of the patients within the first 24 hours will not have these evidence. Now, if someone comes and says this patient came within 2 hours of onset, I would go back and take the history again. You cannot have this much of damage that's already seen unless at least the changes have been there for 7-8 hours. And this kind of a patient, if you thrombolyze, will have a major problem with hemorrhagic ischemic stroke. And also this is irreversible damage that's done. But there are other very subtle signs that will indicate to you this person is going to have a ischemic stroke, not necessarily a hypodensity. And these are some of the findings. We'll try to go by one. Now, when you look at this, you might ask me, how much is too much for thrombolysis? How much is too much for a bleed? Now, the idea is if you have more than 1/3 of the middle cerebral artery affected from the ischemic stroke, thrombolizing, the risk of thrombolysis from a hemorrhagic transformation outweigh any benefits from it. Now, how would you categorize this 1/3? Because 1/3 to me would be a different 1/3 to another eye. So that's where this aspect score came into the picture. So aspect was originated from Alberta Stroke Center in Canada, and they came up with a number given. So what they done is they have put subcortical. You've got 3 areas here, 4 areas of subcortical areas, including internal capsule here, external capsule here, and then 6 areas of cortical regions. So every ischemic damage that's done to this area, you give 10 points to start off with, and you take 1 point off from every damage area. So higher the damage, you'll get a lower score. So for instance, if there's no damage, permanent damage seen at all in these areas, you get a score of 10. Whereas all these 10 areas, that means 100% of your MCA is damaged, you get a score of 0. So this is an objective assessment of this MCA, makes a huge difference when it comes to assessing a patient for stroke benefits and the risk associated. So for a score of 7 or less, so if more than 3 areas are affected, any of these areas 3 affected, that you get a score of 7. If you have 4 or more affected, you get 7 or less. That means you are going to do more harm than any benefit by thrombolyzing these patients. Let's take this for an example. Now you can see this is the area which is affected, already hypoattenuated. That means irreversible damage already happened. You could probably see caudate nucleus is intact, lentiform nucleus is affected, external capsule is affected, and also the cortical areas are also affected. This person has a score of 2 out of 10. This is not someone you will assess and treat with thrombolysis because your hemorrhagic risk is much higher for this kind of patient. On the other hand, this person if you look at this person, there's hardly any difference between the 2 sides. There are no ischemic changes that you could see. So mind you, this is only one slide. This person would have a very higher score, 7 or more. So this is a patient you can proceed and thrombolize. So this kind of a patient should come within 4.5 hours. You looked at the aspect score 7 or more, you could probably safely thrombolize this patient. That's evidence-based safety that's associated with it. So when you assess someone and document, if you say aspect score of 8, and the patient presented within this time, is very clear documentation to say that the person has been assessed properly for the lysis. Right. Now, this is a trick. 80-40, I don't know whether there are any radiologists here in the audience. So we have 80-40 or 90-40 when we assess the CT scan. That's the best window for CT scanning. But if you change it to 35-35, we call it the salt pepper window, you will probably see, you can see very subtle change here, you're not sure, but when you change to that, you will see it better. So when you change the window to 35-35, you will see these lighter changes much more stronger, much more vividly. If you look at you need to change the settings as such. The next one is the MCA sign. Now, this is a fantastic tool, especially with under-resourced center. Now, if I look at this scan, I only have a plain CT, nothing else, no angiogram, no perfusion scan. Or if you only have this, and if you see this line along the middle cerebral artery, which we call the string sign, or the dot within the insula, this indicates there's a large clot sitting in your middle cerebral artery. This patient has, so if there's no parenchymal damage already done, let's say this patient presented within 3.5 hours, you see the string or the dot sign, you immediately know this patient has a high suspicion of a large vessel occlusion and also will probably have a major stroke if you do not treat. So here in Candy, I would probably thrombolize this patient is within 4.5 hours. If I have angio and if the facilities are available, I will proceed to do an angiogram and a perfusion scan. And then if it is feasible, this person will have a clot retrieval. Now, before 2015, we never had PCR. And these kind of patients we used to thrombolize. And if you see this much of a clot, it's more than 1 centimeter of a clot, your chances of recovering from this stroke with a thrombolysis is pretty slim. And probably you might end up in a major hemorrhagic stroke as well. So if you have a 90-year-old or an 85-year-old frail person coming in with this kind of a patient with poor renal functions, you might probably need to think twice, am I actually going to do any difference to this person? Because to get this patient better, you need to have a clot retrieval, not just thrombolysis alone. Right, so what are the other things? The basal ganglions definition. If you look at the basal ganglions here, you can see the caudate nucleus, lentiform nucleus, the thalamus, and the internal capsule here nicely, but that definition is lost in this area. Now, this is a very early sign of an ischemic stroke seen on the CT scan. And if your eyes are not trained to look at it, if you look at for the first time, you might probably figure out this is a normal CT scan. In fact, these changes are going to be irreversible if you treat it with thrombolysis. If you apply your aspect score, you get an aspect score of 6, maximum of a 6 for this patient. And so the same way here, you can see the definition of the basal ganglions are lost in this area. So that is also an early sign of ischemia. Now, loss of gray white matter differentiation. When I speak to my trainees, I always ask them to look at the insular ribbon. Can you see this white line? That is the insular ribbon. That means the cortical and the subcortical demarcation are preserved. And you can see that's preserved, but that's lost in that area. So gray white matter differentiation is lost. That's also a very early sign. Now you can see that our first patient, that was a box standard ischemic stroke. But often in reality, what you're going to get within the first 2, 3, 4, or 5 hours is maybe these subtle signs that you need to understand and recognize. Now, again, very early sign here, and that's after about 1 or 2 days, you can see that has pushed. And so both these cases are contraindication for thrombolysis because the damage is already seen and a very low aspect score. Now, again, these are for trainees. Now, there had been, in my emergency department, there were a few patients like this presented, given aspirin, sent home, and 3 days later presenting with a major seizure and with hemorrhagic transformation. And then when you do the further scanning, there is a tumor underneath. So you can see that these looks the same, but these are totally two different pathologies underneath. Here you can see ischemia within the inferior branch of the middle cerebral artery here, parietal and frontal region, sparing the center of the occipital region. And that does not respect the gray white matter differentiation. It goes straight to the bone, the darkness. Whereas this is a bit funny. It's not in one vascular territory and it stops where your gray white matter differentiation is. And this is called vasogenic edema. This is cytotoxic edema. Vasogenic edema is highly suspicious of something underlying mass. Whereas this is cytotoxic is usually due to a ischemic stroke. And if you see this one, you'll probably proceed with contrast and repeat the scan again and see a damage. The other one is a sulcal effacement. We'll probably proceed because of the timing. Let's do a few cases. So this is a left hemiparesis with neglect found on the floor 1 hour ago. So basically, this person has left hemiparesis and neglect. So we know that the patient has a right MCA syndrome. I'm not going to ask the audience, I'll probably proceed. And you could probably see that changes are already up there. An aspect score, if you look at the aspect score for this patient, you'll see that the caudate nucleus, lentiform nucleus, and the external capsule, more or less gone, and M2 is also affected. So aspect score, and if you look at the top and bottom, further aspect score down, this patient, although they presented with found on the floor 1 hour, most likely this patient was on the floor for a number of hours before the patient was actually found. And just based on the history alone, you cannot thrombolyze someone. You have to probably objectively assess with this person. So this is not someone I would consider lysing. Case 2, onset to the scan, 3.5 hours. So as with my previous one, you can see there's a string sign and a dot sign. Let's say this patient was not in a center where we could perform clot retrieval. This patient will be, within 4.5 hours, will be eligible for thrombolysis because there's no parenchymal damage. Now, see, if you have the facilities, this is the patient, you will do a CT angiogram to rule out confirm the clot, as well as a perfusion scan to see whether the clot can be retrieved. Proceed with lysis. So collapse with aphasia with right-sided weakness, NISCO of 7. NISCO is something that we all use to categorize the symptoms of stroke severity. So if someone coming with the TIA and the symptoms completely resolved, you have a NISCO of 0, whereas if you have a malignant stroke with all the symptoms of ischemic strokes, you get a score of 42. In my mind, usually anything 4 and above, we think as a major stroke that you need to be treated. It goes up to about 20. We hardly see 30s, and they are basically near death situation if you were to do that. So this patient has a NISCO of 7, which means quite disabling stroke. Right-sided weakness, so the left MCA is what we are looking at. But if you look at the scan on the left MCA, there is not much different to the other side here. So aspect score of 9 and 10, you'll proceed with thrombolysis. The next step is the angiogram. So what do we do with the angiogram in stroke? So angiogram with the stroke, why is it useful? Is, as I said, you'll probably see where the clot is. Now, stroke clot retrieval, you can do certain place. If you can't pull the clot out from anywhere from the brain. So you can only pull the clot out if it's in the internal carotid artery, distal branch of the throughout the internal carotid artery. M1 is this horizontal section of the M1 here. And you can retrieve the clot. And this is the superior branch or the anterior branch of the M2. And you can go up to about 2 centimeters here. So here, 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 and the ICA. This is where you can retrieve the clot. If the clot is here or here or here, that's too distal for us to retrieve the clot. And in the posterior circulation, only place you can retrieve the clot is if the clot is in your basilar artery here. Not in your vertebral arteries here. You can't, there's no evidence for that. And also posterior cerebral arteries, you have no evidence. So there's only certain areas you can retrieve the clot: middle cerebral artery, proximal middle cerebral artery, whole of the internal carotid, and whole of the basilar artery. And not considered for other areas. So this is one of the scans that we have seen, that we get at our hospital. Quite pristine findings to make your decisions. Now, finally, about the CT perfusion imaging. Basically, I'll go through very quickly because often we haven't. Can I also ask, what's the facilities available for perfusion scans here?
Why did it suddenly, because of technical issues, the radiologists were not very confident?
You need specific hardware for this. That's the issue we have, and you need to have a 0.3 millimeter cuts to do that. If you have a more than a 1 millimeter cut, then the efficiency of the scan is quite. I agree. Sometimes it's best to not to do the scan rather than trying to do a scan with the bad hardware, because what you don't want is to make a decision based on the wrong information that you get. Yeah, and so. Although it sounds very complicated, it's very easy to read, okay? In a very short way, I'll explain this to you. These 3 scans, mean transit time, and the time to peak, and the delay scans, this area which is in red indicate this is the area which is at risk of developing a stroke. Doesn't necessarily mean it's infarcted. This is going to be infarcted if he hasn't acted on. Whereas blood volume loss, which is a dark, reduction is dark here. If you have a dark area here, that means that area is already infarcted. So what you do is we subtract this from this or any of these ones. And that is the area which can be salvageable, which also calls the penumbra. So for instance, the area that is demarcated as red and the area that is demarcated as black is the same size. That means area which is being shown as can be affected has already been affected. And if the subtraction from this is equal to 0 or much less, you are not going to salvage that brain by doing a procedure. And unfortunately, the time span has gone beyond. Is that kind of clear? That's the easiest or the most simplest way of I can explain this to you. All right. So in other words, this is again the same scenario. Here, the red color was this area. The blood volume infarction was this area. So if you take this out of this, what is left on red here is the salvageable brain that is available. Now looking at this scan here, you can see there's a large area which is at risk. But there's an area which is already infarcted. But you can see, if you can see here, there's still a salvageable area if you were to treat it. Let's do some quick cases here. 75-year-old female at 10:15, sudden onset stroke symptoms, arrived with stroke of 13, left-sided weakness. So we know that it's the right side which is affected. CT perfusion was done with the plain CT, which was perfectly fine. And angiogram revealed a clot in here. So we know that this patient can be clot retrieval. The next question is, can we thrombolize this patient? So you see that in this area, posterior branch of the middle cerebral artery here, there's an area which is at risk, but no blood flow loss, blood volume loss here. So 100% of this, if I were to treat with thrombolysis, I can probably salvage. So you get a bit more information than what you get with the plain CT with these cases as such. So this patient was thrombolized and clot retrieved. And this was the MRI scan we done. This was the last infarction that the patient left with. And if you, on the other hand, if you haven't treated, the patient would have ended up in a bigger stroke as such. So this was a mitral valve repair 2017 replacement. Was on warfarized, ceased for some time, and came in with a right tax, NISCO of 18. So quite a large strokes with a right tax. And I don't know whether you could see, you can see the string sign here already on this scan. So this is a patient who has got a large vessel occlusion, still within the time of window. Again, looking at this scan, large area which is going to infarcted, but not so much on the blood volume. So fantastic case for thrombolysis and clot retrieval because we can reverse these symptoms as such. And that was the angiogram there. And outcome was again smaller stroke. Still, you are going to get some form of a stroke from that because there's going to be some time getting this clot out. You can see that change here. Now, this was a lady, Mrs. Young. This was around before COVID. That's presented to us. See whether this video works. What's your name? FA6, she's densely weak on that right side. She was a shop assistant, completely modified ranking scale of 0. And presented with a left tax, aphasia, symptoms 3 hours ago. And fortunately, she was actually not too far from the hospital. She came in within quite a shorter period of time. And this was her scan, sorry. Okay. And it was seen. So what happens is the process is that we don't have ECR facilities in the hospital where I live. I will explain to you about what the Australian facilities are like at the moment. So we call up, while we thrombolize the emergency department, call up the ambulance services, they decide whether to airlift the person or road transfer. And you could see it's a multidisciplinary group that comes in. Nurses put the lines in and we make the decisions. And while the other doctors take 1 hour 34 minutes for the ECR center. And funny enough, if you actually, this is by road, if you take it, if they airlift, it takes about 2.5 hours to get there because you need all the practicalities. And we've been fighting for us to tell them we don't need a helicopter, we just send them on road. But the protocols are a bit different and it's a bit difficult to break that. Right. And so this lady, I wanted to find out what's the outcome of this. And this is the stroke neurologist from the tertiary center said, mentioned lots of clot came from the ICA origin to M2, but all curves came out and able to move right hand. And she was fantastic and walked away after 3 weeks into the hospital. Right. So I just wanted to give you an idea about how things happen there. Now, age is not a barrier for these treatments. And this was a patient, I don't think this lady was clot retriever, she was thrombolized. She was 95 years of age. But like a 65 years, she was perfectly independent and had a major improvement with the stroke thrombolysis. And in fact, one of the local papers got her to give her story as well afterwards. So any patient comes here, just assess the patients based on the functional modified ranking scale is a very good assessment tool, not based on just the age. But from my experience, who are the patients who have red flags? Are the patients who have got lots of white matter changes on the plain CT. Some of these could be cerebral amyloid disease that can easily bleed. If you have a very bad CKD grade 4, 3B, 4, or 5, you have to be cautious about these patients as well. Right. So wherever you live in the world, whether it's in Sri Lanka, whether it's in the UK, Australia, we all have challenges. And the cases that I have presented you are the ones that's gone really well. Yeah? I'm not trying to paint a picture here to say that everything is like this in real world. We have major issues up there as well. And the first one is the time taken to take a patient into the hospital. I'm sure being in Sri Lanka for a long time, I know most of these can be translated here as well. Even there, my major, the district that my hospital provides is the geographically very equal to the geography of Sri Lanka. So I can put Sri Lanka just into the district of where my hospital provides. I have a population of 250,000 though in that geographical area, yeah, as opposed to 26 million now. Yeah. And so small amount group is small, but getting patient from A to B is a major problem. Sometimes patients present to me after 1 day of clot, and also most of these patients are not educated properly. They take a while to call. Resource availability. Now again, CT perfusion scan for the whole of that area. I have one in my hospital and another regional hospitals. No other place has CT perfusion scans there. CT angiograms, we can do it in some places, but not in all places. So plain CT, there are some hospitals which we don't have even a CT scan. So this is a first world country, and in the UK is a bit different because UK is a smaller country, and most of the hospitals are well equipped. But in Australia, there is a significant vast difference between the best hospital and the worst hospital. And some of the places there are some patients who come and see me just in my private rooms coming from 800 kilometers. They travel for a whole day just to come for a half an hour appointment and go back. And their mindset is such that if you offer them telehealth, they would still not take that. Right, then the patient selection and the cost. They are all challenges that we face. Okay? This is the Australian, we talked about how many we have here in Sri Lanka. Even in Australia, we do not have enough of clot retrieval centers. So this was the latest data. You can see my hospital is here. My closest hospital is in Brisbane, and there are 2 centers there. So there are only far and few in between when it comes to centers which can do clot retrieval. So how does this translate to patient care? So you can see, I'm not sure whether this is how clear this is. These lines indicates the smaller hospitals, and some of these hospitals, even the receiving hospital does not have all these facilities that we have. Although we boast that first world countries have the best care for acute stroke, we also have a long way to go to have each and every of these patients treated the same way. So a patient having a ischemic stroke here around Brisbane is vastly different to a person who's having a stroke here in the middle of Australia here. There's a lack of facilities that are still available and have to work on. And these are, to get from here to here, if you are driving, that's 9,000 kilometers to get from here to here. And that's not fun. And you need to get the air ambulance to work on that. So when I prepared this talk, I wanted to know what Sri Lankan guidelines suggest at the moment. And most of the latest guidelines, I'm assuming this is the latest that we have. And what is suggested is there is a clear section on stroke thrombolysis, and these guidelines are not any different to what we have as such. I wanted to find out whether there are guidelines for, these are for thrombolysis. I wanted to find out whether there were guidelines for clot retrieval, and we don't have it, but I can understand why it is, because there's hardly no use having guidelines if you do not have the facilities to do that. Right, and this is another study. I don't know whether some of you are already here who has contributed to this, another trial that's done. If you look at this section here, this is the door to needle time. Now, golden time is 60 minutes. When someone comes to the hospital, you need to thrombolyze within 60 minutes. But here, we take about 174 minutes to thrombolyze because of the logistics we have. If I were to do that, the short time I've been in Sri Lanka, I know that to get to a CT scan, and it's a very busy CT scan, and to get that organized and cleared up for a patient is difficult. Getting this patient organized, everything is different. Now, you might ask what's the Australian standard is. Some of the hospitals are hitting 60%. In my own hospital, I'm struggling, and I'm still at about 105 door to needle time. And the way to do that I'm planning to do is to thrombolyze the patient in the CT scan, and that gets a lot of time away from from a patient as such. So we have got a long way to go, especially with the Asian countries. But some of the centers are not far off, and the only way to do that is to probably to get our resources more. And we've got again, I know if you look at the nurses, you would not get the best nurses as we find here. And I was actually descaled going to the UK, not being able to put a cannula in because my nurses all did all that for me. And that was the most difficult thing for me to learn when I went to UK. And even the doctor's skills. We are far better off, or we are on par with any other world when it comes to doctor skill and the personal skill as such. What we struggle here is to get the resources. And in a third world, if we have the same facilities as we have elsewhere, we would probably be leading the world. And that's what I have seen working in 3 different health sectors. And I was fortunate enough to do that. Right. So what do this is another way of reducing it. So this is basically when a person has a stroke, we get this, let's see whether I can get this going, phone to say that the results are at the top. And this patient, artificially how the patients are well. And sometimes on night reliable. So let's say I was in a supermarket at this call, straight away looking at my phone and ask the emergency department to proceed with thrombolysis or clot retrieval for these kind of patients. So this is a technology that is being available, and indicating that red means things that have been implemented to improve the patient's, the clinician's skill. These tactics trials, our hospital was involved in this trial as well. This is artificially generated software with a VR set that you wear, and it takes you through a simulated environment where you are the emergency doctor, and these patients are coming in and they give you the history, and you have to click where your process is. There are about 6-7 cases, and we were part of it. And there were 2 groups who did not use this, as well as another group who did use it, and they found out how the knowledge base has changed, and what is in black is after. And what was found was their confidence in managing strokes were significantly high. So these are the kind of initiatives that's taken up to improve the clinician's knowledge, which will benefit the patients as such. Right. So this is a final few slides of me. Can we implement hyperacute stroke service with a CT scan head alone? That's the question we have here, isn't it? No use speaking to everyone about perfusion scan and the CT angiogram when we do not have the facilities to do a CT. What can we do with what we have is the question. So answer is yes, we can still do a lot of things with the plain CT alone. Thrombolysis up to 4.5 hours. Absolutely, you do not need any other modality. You can do it with the plain CT. Prediction of a large vessel occlusion. If you see the string sign or dot sign or the bacillar sign, you can probably predict these and then get the patients, because we got about longer time period for this. And if facilities are available in the future, these can be still. But unfortunately, without advanced imaging, we can't thrombolyze a patient beyond 4.5 hours up to the extended time window, or we can't consider someone for clot retrieval. Right. I have to show you the other one. Yeah. So this is, my talk is all done, and this is all fun. So Toowoomba Hospital decided to look at helping out MD trainees from Sri Lanka. And we have about 25 advanced trainees, equivalent to our MD trainees. Some of them are actually in the college approved program. Some are like principal house officers. So I had some contacts from Runa as well as Anuradhapura, and some of the advanced senior advanced trainees who have completed the training. We recruited 8 to the hospital, and there are actually 10 out of 10, 8 are there. This is a small function at my place, and we had great fun. And these guys are fantastic. That's their families, all families from, as you could see, and they provide a fantastic service to the hospital as well. Got a very big regard as well. In the future, what we are planning is that I wanted to make sure that the first batch comes and does a good job, so that it will be a rotational process, and the hospital is quite happy to plan for future trainees as well. So I'm happy to help out anyone who's interested. We have filled the next year's program, and the computer is telling me not enough. Yeah. So this, by the way, that's my friend Uday. So I know that he's a avid cyclist here, and he has continued to do that there. He was telling me the cycling that has happened from Kandy to Polonnaruwa and come back again. And he's a great asset to the hospital. He's a leading gastroenterologist here in our hospital there, and the full-time gastroenterologist, and we are very fortunate to have him there. Thank you. That's it from me.